Welcome to my YouTube channel. Today we're going to talk about management of venous thromboembolism in pregnancy. Thank you to make sure you subscribe. It will cost you absolutely nothing. So let's dig in. We're going to start with the definition of venous thromboembolism in pregnancy. And just from the name, this is venous meaning in vein, and then thromboembolism is the presence of a blood clot, and then in pregnancy. So under venous thromboembolism, we have two. Under the umbrella of venous thromboembolism, we have two common things, and the first one is deep venous thrombosis. And in deep venous thrombosis, this is when you have a presence of a clot in one of the deep veins. And then in pulmonary embolism, this is when you have the presence of a clot in the lungs. So how does pulmonary embolism develop? So already we know that in DVT, we already have the presence of blood clot in the deep veins. And one of the deep veins you can mention maybe is popliteal artery. So when that clot dislodges and then it is now circulating to the blood flow, where will it go? It will travel into the pelvic veins and later find itself into the inferior vena cava and later travel up into the right atrium, right ventricle, and it will be pumped in the pulmonary system and it will dislodge itself in the pulmonary artery, either right or left. So what is the cause of venous thromboembolism? And we have a theory that is the virtual triad, and under this theory it is said that we have three factors that contribute to the formation of a clot or development of thrombosis. And one of the factors is hypercoagulability, and hypercoagulability is when the blood has a tendency of forming clots. And one of example is when, for example, you have thrombophilus, that is genetic conditions, or cancer, or for example pregnancy, which is an hypercoagulable state. The next is status. This is when you have abnormalities in blood flow. And endothelial injury, this is when you have damage to the inner lining of the blood vessel, and that this can occur during surgery, can occur during physical trauma, and for example in insertion of intravenous catheters. So we're going now to go to management or treatment of venous thromboembolism in pregnancy. And what's our main problem? Our main problem is formation of blood clots. So the medications that we're going to give are going to prevent formation of these blood clots. So which medications are we going to give? We are going to begin to give anticoagulants. So we are going to discuss briefly the classes of anticoagulants. And the classes of anticoagulants we have indirect thrombin inhibitors, we have direct thrombin inhibitors, and then we have vitamin K antagonists. So in terms of indirect thrombin inhibitors, we have the heparins. And in terms of the heparins, we have unfractionated heparin. We have low molecular weight heparin, that is enoxaparin as an example. We have synthetic heparins, that is it's synthetic heparin pentasaccharide, that is fontaparinax. And then now those are the heparins. And then lastly, under indirect thrombin inhibitors, we have the new oral administered factor 10A inhibitors, and examples we have rivaroxaban, apixaban, and endoxiban. So these ones are not given in pregnancies. So direct thrombin inhibitors, we have agabatron, we have lepirudin, we have bivalidrin, and then we have dabigatran. And so in direct thrombin inhibitors, the first three are IV medications, and then the last one is oral. In indirect thrombin inhibitors, all of these are IV medications, and then or subcutaneous medication, and then the new oral administered obvious oral, meaning it's an oral drug. And lastly, we have vitamin K antagonist, which is warfarin, which is totally contraindicated in pregnancy. And the reason behind this, you're going to see in the next few slides. So we already looked at the classes of anticoagulants, and the most or the preferred drug that we in the anticoagulants we use are the heparins. So we're going to take a look at the different types of heparins, and the first one is low molecular weight heparin. And low molecular weight heparin, this is the preferred drug which is given in acute thromboembolism. So examples of low molecular weight heparin include the parins, that is enoxaparin, we have dalteparin, we have nadroparin, we have bemiparin, satoparin. So anything that has parin is under low molecular weight heparin. So the most commonly drug used is enoxaparin, and the dose that we give is 1 mg per kg every 12 hours. And it's only feasible in patients who weigh less than 150 kgs. And the reason for this, that is low molecular weight heparin is excreted by the kidneys. So if you are going to give this medication. So for example, if you calculate, this will be 150 mg every 12 hours. That can bring problems in terms of clearance. So if a patient comes in, they have kgs that is greater than 150, we give unfractionated heparin. So the mode of administration is subcutaneous, and then we monitor low molecular weight heparin by anti-XA. The reason for this, the mode of action of low molecular heparin is it stimulates antithrombin 3, which then inhibits factor 10A. So then it will make sense if we monitor low molecular weight heparin by monitoring anti-XA. So the next thing, what are the advantages of low molecular heparin that we are using or we are seeing that is the preferred treatment? The advantages is it has more predictable therapeutic response, it is easy administration and monitoring, and then it has less heparin-induced thrombocytopenia. One of the side effects or one of the adverse effects of the heparins is heparin-induced thrombocytopenia. This is when you have low levels of thrombocytes, and in terms of low molecular heparin, it has a lower effect. So the disadvantages is the cost is higher, and then it has a longer half-life. Remember that the patient we are treating is a pregnant woman. So if it is in the what semester, if it is in that semester and maybe want to go for CS, then it will take a longer period for the patient to be out of anticoagulants in comparison with unfractionated heparin, which has a shorter half-life, and it is advisable for patients who are now in last trimester. So as I said before, it is excreted by the kidney and should not be used in patients who have problems with kidney failures, that is patients who have creatinine clearance which is less than 30 ml per minute. So in terms of unfractionated heparin, it's the next drug of preferred after low molecular heparin. So what are the indications? For example, when you have immediate surgery, and the reason for this is because it has a shorter half-life. So yes, shorter half-life, and the reversibility with protamine sulfate is easier, or it is faster compared to low molecular heparin. In addition to that, in patients, so unfractionated heparin is excreted by the hepatics, that is the liver. So in patients who come in and they have kidney functions, then we advise you to give unfractionated heparin. This is because it can be used in patients who have creatinine clearance less than 30 ml per minute, and also in patients, as we said previously, who weigh greater than 150 kgs. Also, it has its cost effectiveness compared to low molecular heparin. So how do we monitor? We monitor it using APTT, and also we make sure even when we are monitoring it using APTT, and make sure that the target of our APTT is 1.5 to 2.5. We also monitor platelets, and the reason behind this is because unfractionated heparin has a higher chance of us developing heparin-induced thrombocytopenia. And what happens there, we have an immune-mediated reaction where we have decreased levels or consumption of platelets. So we have to monitor them so that for us to get the adverse effect. So in acute, so we said in previously in terms of low molecular weight heparin, we give it subcutaneously. When we use unfractionated heparin for acute cases, we first of all give an IV bolus, and then we follow it by an IV infusion, and then we titrate the dose to our target APTT, that is 5.5 to 2.5. So in acute stage management, our loading dose will be 70 to 100 units per kg. So a normal human being, what is the approximately 70. So if you multiply that, but you have to take the kgs. And then 15 to 20 units per kg per hour. And then when the person is out of acute stage, then we put on heparin 5,000 to 10,000 units twice daily, and this is usually subcute. So, and as we said before, the target of our APTT is 1.5 to 2.5. So we go now to warfarin. Warfarin, it's only used, I said warfarin number one, it freely crosses the placenta, and that is categorized by FDA as the category X drug, meaning it's not supposed to be used. However, in some certain scenarios, we actually use warfarin. And certain scenarios include, for example, patients who come in from developing countries and they don't have money for the heparin, and warfarin there is cheap. So let's now look at the side effects before I tell you when we will give this our warfarin. So our first side effect is teratogenic effect, and the teratogenic effect is mostly occurring at the first trimester, that is 6 to 12 weeks. And this will cause a syndrome called as fetal warfarin syndrome, and this patient will come with, after they are born now, with chondromalacia punctuate, with mid-face hypoplasia, with stripped chondral calcification, with silicosis, and with short proximal limbs and fingers, that is bradycardia. Then we have fetal hemorrhage. So in fetal hemorrhage, it is mostly during and immediately after birth. Then, meaning if you're using heparin, then you should discontinue it at 34 to 36 weeks. So in a scenario, then you have a patient and the patient comes in saying that I totally don't have money to pay for the heparin injections, and then you must give them warfarin because you have to treat you have to treat the VTE. So the following is what you will do. Number one, you're not supposed to give them in the first trimester. So you begin after the first trimester. And then when we are now going to the third trimester, the last trimester, you discontinue heparin. So it is kind of safe to give heparin in the middle between the first trimester and the third trimester. So the more if you give heparin, if you give warfarin and the patient comes in now in labor, the mode of delivery you have to do is cesarean section to avoid a lot of bleeding. And for the neonate who is born in a mother who was taking warfarin, then you have first of all to reverse because you say it passes the placenta. And the reversal, we have two reversal, where we have direct reversal or fast reversal, where you give fresh frozen plasma, that is FFP, or you give vitamin K, because warfarin it's a vitamin K antagonism. So which takes time, which is now the indirect. So now what happens? Now let's look now deeply what happens when you give warfarin in pregnancy. So when you use warfarin in pregnancy, then we said it crosses the placenta. So when it crosses the placenta, the mode of action of warfarin, as I said, it's a vitamin K antagonism. So it inhibits vitamin K regeneration by the reductase enzyme in the fetal liver. Now we are in the fetus. So in the fetus, now we'll have decreased vitamin K, and in addition to that, we'll also have so when we have decreased vitamin K, which acts as a cofactor of glutamine carboxylase enzyme. This glutamine carboxylase enzyme usually add carboxyl because it's a carboxylase enzyme. It usually add a carboxyl groups to the glutamine residence of which factor? These ones you have to know: factor 2, factor 7, factor 9, and factor 10. Factor 2, factor 7, factor 9, and factor 10. So now, because we don't have these factors are not active, we are prone to bleeding. So then we have decreased production of the clotting factor 2, 7, 9, and 10. So in the fetus, we'll have increase of bleeding. So the patient can bleed, for example, intraventricular hemorrhage, among other bleeding. In addition to that, it can also cause spontaneous abortion. In addition to that, it can also cause fetal warfarin syndrome, which I mentioned in the previous slide, and I want to mention it again. So the fetal warfarin syndrome, which is also called warfarin embryopathy. So as we said before, this is when we said warfarin is teratogenic. So when we have exposure of warfarin in the first trimester of pregnancy, then we are going to have fetal warfarin syndrome. So what are the clinical features, or how will the neonate present? We have skeletal abnormalities where we have stripped non-calcified epiphyses. So it tends to affect now the cartilages or endochondral calcification, shortened fingers, that is brachydactyly. We also have nail hypoplasia and silicosis. The next, we also have facial abnormalities where you have nasal bone hypoplasia. We also have nasal bridge depression, and as you can see here. And the third one, we also have CNS, and in CNS it usually causes intellectual disabilities when the child grows later in age. It can also cause seizures, and also cause ventriculomegaly. So clinical path. So this is just a summary of what we have been talking about. Which drug did we say is best for patient who comes in with a VTE in pregnancy, we say the heparin. So which heparin? We said low molecular heparin. However, you can use unfractionated heparin. So in some circumstances we don't have heparin. So what do? We put this pregnant lady for first trimester on heparin until 14 weeks, because we said warfarin has a teratogenic effects which are going to cause her to have fetal warfarin syndrome. So now from the 14 weeks to 36 weeks, you can now put the patient on warfarin, and the dose is 5 mg OD depending on the target. So you're going to use your INR to get the dose, but you're going to start the patient to 5 mg OD, and then now you're going to monitor. One disadvantage of warfarin is that it requires regular monitoring. So the target INR is 2 to 3, and then from 36 weeks, then you put the patient on warfarin. The reason we said because it has increased fetal hemorrhage, and we said warfarin can cross a placenta. So from 36 weeks, you place the patient on warfarin. So if prior to delivery, you usually withdraw our lower molecular weight heparin for 12 hours, and then now after postpartum, you put patient back on warfarin, postpartum on warfarin, and then you continue the treatment from 6 to 12 weeks postpartum. So assume that the patient comes in, they have money, they don't have financial problem, they don't have contraindication for heparin. Then you continue with the heparin throughout the pregnancy, and prior to delivery, you withhold the heparin 12 hours to delivery. And then after the delivery, you put the patient on postpartum on heparin. So what are the complications? The first complication and the most complication, because our most drug that you're going to use is heparin, and the first common complication of heparin is bleeding. The second one is heparin allergies, that is heparin-induced thrombocytopenia, which is said is most commonly in unfractionated heparin. And how are you going to know that this patient is in heparin-induced thrombocytopenia? The first one, after you give heparin, always make sure you monitor your platelet counts, and you can have platelet counts when it drops greater than 50% or more from the baseline. And then if it drops below 100 times 100 times 10 power 9 per liter, or when you have presence of skin necrosis. One of the clinical features, or one of the observations that you're going to see in heparin-induced thrombocytopenia, at the injection site usually have skin necrosis. So if you have that, or you have new venous or arterial thrombosis, which occurs after the initiation of heparin. So how are you going to treat a patient who comes in? You've been giving them unfractionated heparin, and they come in with heparin-induced thrombocytopenia. The first thing, you discontinue heparin, and then you continue with you don't give platelet transfusion. I have a video on heparin-induced thrombocytopenia, and heparin-induced thrombocytopenia is an immune disease where heparin normally binds on platelet factor 4. So that complex, heparin and platelet factor 4, then it kind of causes the body to form IgGs that attack that complex. So when it attacks that complex, then more platelets are involved in that complex. More platelets will be involved and will also be destroyed in the process. So when you give platelets, is now your treatment, because you saw the patient has come in with low drops of platelets. The platelets have fallen to 100. Most medics will think, now let's give platelet transfusion, but what you'll do will just be feeding into the arterial or venous thrombosis. It's kind of, you'll be worsening the problem. So what you do, you stop the heparin and you give direct thrombin inhibitors. What are the examples that we said of direct thrombin inhibitors? What did we say? The Batras and the Deans, Lucidinine. Yeah. So you can, if you're forgetting, you can check you can just move into the previous slides. During and labor and delivery, just a repetition of most of the things that we have said. And number one, we have temporary discontinuation of the anticoagulant, and the reason for this is for availability of regional anesthesia. So if you already anticoagulants, one of the risk factors we say is bleeding. So an hematoma can develop if you fail to discontinue the anticoagulant. In addition to that, as I said, it reduces the risk of epidural and spinal hematoma. So in terms of low molecular heparin, usually switch 24, it may be switched to unfractionated heparin before term, usually at 36 weeks. And the reason for this is say that unfractionated heparin has a shorter half-life, and it is advisable when the patient is going into immediate surgery. So, and with that, then you monitor the unfractionated heparin using APTT, and then another reason is it can be easily reversed compared to low molecular heparin by protamine sulfate. So, or you discontinue heparin 12 hours following the last prophylactic. Remember, in this case, we are talking about treatment, so it was not prophylactic, low molecular heparin, or 24 hours following the last therapeutics for our case, it will be therapeutic low molecular heparin dose. So in terms of postpartum, then you can return, or you can now continue the heparin or unfractionated heparin 4 to 6 hours after vaginal delivery and 6 to 12 hours after cesarean section. So prophylaxis for VTE or venous thromboembolism. Who do we give prophylaxis in terms of pregnancy? We give a patient who has been diagnosed with venous thromboembolism during the previous pregnancy. We also give a patient who has an history of venous thromboembolism during pregnancy or use of hormonal contraceptives. We also give a patient who comes in with a history of thrombophilias without personal or family history of venous thromboembolism.